So, welcome everyone. Thank you very much for attending this, our final webinar on cancer care, organised by the WFSA Pain Management Committee. My name is Clare Roques and I'm the chair of that committee. And I'm just here to welcome you all to this event before I hand over to my colleague Gauhar Afshan, who is organising and chairing the event. So thank you very much to you all for coming. Thank you for our panellists, and thank you to the team at the WFSA for making all this happen. Just some technical formalities before we get underway. Everyone apart from our panellists and speakers will be automatically muted and the cameras will be off. Some of you will be joining us from Spanish or English speaking countries, and we do have people joining us who may be speaking Spanish, so we have language interpretation available. Please, to ensure that you can hear today's discussion in the correct language, can everybody, including the English listeners, go to the globe icon at the bottom of your screen and select either Spanish or English. The session will be altogether an hour and a half, including some time at the end for discussion. So please feel free to put some questions in the Q&A function at the bottom of the screen, and we'll answer as many questions as we have time for, and we will put these to our panellists. The webinar will be recorded, and we will let you know afterwards how you can view the recording. So without further ado, I will hand over to our chair, Dr. Gauhar, and I really hope you all enjoy it. Thank you very much for coming.
So thank you very much, everyone. Thank you very much of the participant who attended this webinar. Here I'll just give a very brief introduction of the program. Today we'll start our webinar with a state-of-art lecture by very, very famous, we all know that, Professor Roger Goucke. He's a foundation fellow, former dean of the Faculty of Pain Medicine, head of the pain medicine at Sir Charles Grenadon Pain Management Center, and the president of the Australian Pain Society. And he introduced, and he's really working hard for EPM in the LMIC. And this would be followed by a very interesting panel discussion. And for this panel discussion, we choose, the Pain Management Committee, WFSA, choose a very interesting, title: the Cancer Pain Relief Without Opioids, a Challenge in Lower Middle Income Countries. And this would be moderated by Dr. Usman Bashir. And I will introduce the Dr. Usman Bashir a little while. This is a multidisciplinary panel, and I hope that you will enjoy this today's webinar. So let me introduce the Dr. Usman. Dr. Usman Bashir is fully trained. He's trained in the UK. He's a fully trained pain consultant. Currently, he is the leading pain services in the King Faisal Specialist Hospital and Research Center, Saudi Arabia. In Pakistan, when he was in Pakistan, he introduced the EPM and made a lot of efforts. He's an academic physician and has a lot of interest in all these academic and education program in pain medicine. So I think I'm now handing over to Usman Bashir to start, not Usman Bashir. Now I will introduce the Dr. Roger, the Professor Roger. And Professor Roger, I think you need no introduction. So please start your topic. Title of the topic of Professor Roger is WHO Analgesic Ladder 1986 to 2023, an update. Professor Roger.
Thanks. Thanks very much. I will share my screen with you, and this will be the challenging part of the whole session. Okay, so hopefully everybody can see these slides. This topic, which has been I guess a very challenging topic, that is the use of opioids in cancer pain, has been promoted by the World Health Organization, and it started really formally back in 1986 with the World Health Organization ladder. And the ladder has been revised by the WHO in several years ago. So that's what I'm going to talk about. So many of you will know, this is the original ladder. And the book on cancer pain relief in which this ladder came was published back in 1986 by the WHO, and started with pain, non-opioid management of pain with an adjuvant, and we'll talk about these in a minute. If the pain continues, one goes on to a weak opioid with the use of non-opioids and an adjuvant, and then if pain persists further, one goes on to a strong opioid and a non-opioid and an adjuvant. So that's how things were in 1986. At the same time that this publication came around, it didn't just promote the use of drugs, and in particular opioids. It looked at total pain. And I think these are very important components, particularly where opioids are not available in many developing countries. So there's a list of, I guess, issues that also need to be addressed when one's looking at cancer pain. And they're listed here. And they really look at the psychological components that people present with in addition to their pain, and these can all be amplifiers of their pain. And so clearly they need to be addressed. So as I said, the World Health Organization revised their guidelines in 2018, and I'll talk a little bit about what they're recommending now. So here's the original 1986 on the left, the ladder on the left, and the ladder now on the right. It doesn't look very much different. The things that are different are that the WHO have used different terminology for opioids. So in step 1, there's no change. Step 2, they've taken away this concept of weak opioids. And in step 3, the concept of strong opioids. They're just suggesting opioids. So that's really the only change. And we can talk about what that means. So every country, and I'm sure many of the participants of this webinar will have their own concept about what weak and strong opioids are. And this is an article from the British Journal of Anaesthesia just last year. And they're discussing what weak and strong opioids are. And as you can see, I've highlighted here the place of codeine. This is in the UK's thinking, and tramadol. One of the problems with labeling drugs as weak or strong is that there's no clear definition. And the UK, the British National Formulary, says tramadol is a strong opioid, but the WHO defines it as a weak opioid, which is difficult if one's trying to promote some standardized way of looking at this. And I'm sure in the discussion, we'll discuss, or there will be some discussion about what weak opioids are available or what non-morphine opioids are available in different countries and how valuable they are. So here's the list. So you can see on the left in 1986, non-opioids, weak opioids, and strong opioids. So there's aspirin with an alternative of paracetamol for non-opioids. The weak opioid was codeine, and then there was dextropropoxyphene, which is essentially left certainly left high-income country markets. And then there are a whole list of strong opioids, such as morphine, methadone, pethidine, buprenorphine, hydromorphone. And on the right, you'll see there has been some changes. Paracetamol is still present. There are many, many more NSAIDs that have come along since 1986. So aspirin has really been, although it's still there, it's been replaced by the multitude of non-steroidal anti-inflammatory drugs. The WHO in the list, in their document, although they don't have it on their ladder, still use weak and strong opioids, and the only weak opioid is codeine. And there's a range of strong opioids available in addition to morphine. The WHO have also continued to publish quite useful documents, and here's one that's just come out this year that's a follow-up to their new ladder called Left Behind in Pain. and it looks at the global variations, which I guess we're going to talk about, and what are the barriers and what are the actions that we can do to promote safe access to opioids. So here we are. Here's the new ladder. Now, one of the challenges with this ladder is, do we need step 2? So most practicing clinicians would either use a non-opioid and an adjuvant and then go straight, if that's not good enough for pain relief, we'll go on to use an opioid. So there's an argument about, is step 2 necessary? You can either give a little bit of opioid or an increased dose of opioid. And so one of the ways of trying to sort this out was this study, which is from, it's a multi-center study, but was written by Marie Fallon in Edinburgh. So this is an international open label randomized trial looking at whether there is a difference with putting a 2-step or a 3-step ladder. It's quite a difficult study to do, and it took them quite a long time. So it took 3 years, and their aim was to get 200 people in both groups. They looked at people who had pain greater than 4 out of 10, and then they treated them either with an opioid or with a non-opioid, with a goal as to get the pain less than 4 out of 10. And the conclusion was that there was no difference between the 2 arms of this study. So it made no difference if you had a 2-step or a 3-step ladder. So they made a strong argument that there is evidence that you don't need the 2nd step of the ladder. So just file that away. And it's probably what we do in general medical practice or cancer pain practice now. Let's look at the adjuvant drugs that are available now. In 1986, they were anticonvulsants, which essentially was carbamazepine and phenytoin for neuropathic type of symptoms. There were a lot of psychotropic drugs, the chlorpromazine types, haloperidol. So these are really major tranquilizers, and there were steroids. Now, there's been a revolution really in adjuvant drugs with the antidepressants such as amitriptyline and the SNRIs such as and SSRIs, venlafaxine and duloxetine. The anticonvulsants of carbamazepine are still present. And of course, now we would add in bisphosphonates, but they're not primarily seen as an analgesic agent, but they're useful for bone pain. And steroids, and I'll talk a little bit about steroids. They're not usually noted as being an analgesic agent by pain medicine physicians, but they're widely used in cancer pain, and it's worth considering their role. So to try and look at evidence for the drugs that we currently use, Cochrane's always a good place to start. And Cochrane have done a review of the place of opioids, morphine in particular, in the management of cancer pain. So this is a review of reviews. So Cochrane review of meta-review of reviews. So they found 152 studies, a large number of patients, 13,500, and they all had moderate to severe pain. Not surprisingly, there were very few that had a placebo arm control. So it's non-placebo controlled. And the major design of most of the studies was the dose of the drugs used was to titrate the dose to effect or an adverse effect. So they were giving them maximum doses. So that's the Cochrane review. And the bottom line really was that 19 out of 20 participants with moderate to severe pain, so a lot, would get down to mild or no pain at 14 days. So they're saying that opioids work. However, most people will experience an adverse event. And 10 to 20%, that pain, that adverse event will be intolerable, so they'll have to stop. So they do work. The bottom line is morphine remains the gold standard opioid, but there are significant side effects if there's dose escalation, which is often the case. So let's briefly look now at non-opioids and non-opioid, non-pharmacological options. So these were the things I mentioned as we started, the things that patients worry about: their money, their family, their anxiety, their fear of death. So these very important issues, which in general, medical practitioners are not good at, nurses are better at managing. The idea was to use a person-centered approach, explain and discuss, and then try and modulate stress with relaxation, meditation, and problem solving. So that's something that can be used without opioids. Pharmacological, non-opioid pharmacological options, we mentioned paracetamol. NSAIDs can be either selective or non-selective. I suspect in low middle-income countries, ibuprofen and diclofenac are the common ones. And remembering that there is good evidence for paracetamol and an NSAID to be used together, so they work synergistically. We know that paracetamol, I know many of you will know this, but paracetamol, we're not quite sure how it works, whether it's COX-3, works in the brain somewhere. It benefits some conditions, but not all. So it's good for tension type headache, but not good for back pain, for instance. Tension type headache and acute postoperative pain. It's relatively safe. We need dose reduction in the elderly, and there is liver toxicity in high dose. NSAIDs, again, modest benefits for nociceptive inflammatory pain. There's low evidence for prolonged use, and there's a significant side effect profile, especially in the elderly. So one, as a mantra for the use of NSAIDs, is use the lowest dose for the shortest period. So the WHO in 2018 did look at evidence for step 1 and step 2. There's multimodal treatment used with paracetamol. This is what WHO is saying. And they were a bit vague about the place of weak opioids. For the use of adjuvants, the WHO reviewed the literature and they came to no recommendation for the place of antidepressants, no recommendations for anticonvulsants. For bone pain, they found strong evidence for the use of bisphosphonates. And if they looked at monoclonal antibodies, which I wouldn't normally classify as an adjuvant, but the WHO did for pain. Now, we mentioned steroids early. That was present in 1986 and again in 2018. So the indications for steroids, this is WHO, metastatic bone pain, neuropathic pain, and visceral pain. So most pain physicians would not be clear that that is a good indication, but that's what the WHO are recommending for cancer pain. They reviewed 7 low-quality trials looking at methylprednisolone, dexamethasone, and prednisolone. And their recommendations or their guidelines are there's moderate quality evidence that they probably improve pain and may improve quality of life. So maybe there's some value. They talked about side effects, but didn't quantify them. And they talked about the psychiatric concerns with high-dose steroids. They didn't make a comment about the dose, how much to give, the duration, or what's the length of effect of administering steroids. So there were lots of open-ended questions for the use of steroids, but they're recommending them to a certain degree. There's a bit more evidence to guide us when we're thinking about steroids for cancer pain if we don't have opioids. And there's an Australian review in palliative medicine in 2021 run by Janet Hardy. They looked at the evidence-based quality for corticosteroids in palliative care in patients with advanced cancer. And it's quite a nice review, and I'll briefly discuss it with you. So they acknowledge that steroids are widely used for a range of indications in cancer pain and palliative care. They acknowledge that side effects are common and often debilitating. And they say that their use is often not consistent. with the principles of quality use of medicine. And that's code for there isn't evidence base for their use. So their review came out with support for the use of steroids in spinal cord compression, raised intracranial pressure, malignant bowel obstruction, lymphangitis carcinomatosis, and superior vena cava obstruction, which I guess most of us wouldn't have any concern about, but that's treating the condition rather than pain. They also said steroids, short trial in the management of pain and cancer-related anorexia. The benefit in other symptoms is unknown. Low-dose steroids, that's under 2 weeks, unlikely to give toxicity apart from hyperglycemia. So diabetics may be an issue here. And they reinforce that dose-related adverse effects are common if steroids are used over 3 to 4 weeks. So maybe we don't need the middle ladder. I'm sure we'll talk in the next session about whether there is a fourth ladder. So there is an argument that if morphine does not work, interventions are useful, and in selected people, there's no doubt they are, and that they may have a role in very selected population in developing countries where these facilities are available. And I won't say any more about that. Very briefly mention these atypical opioids. We started off with a discussion about whether tramadol was a weak opioid or a strong opioid. It is widely used in North Africa, I'm aware of, and I don't know about its place in India and Pakistan, but I'm sure we'll hear. The atypical opioids, buprenorphine, tramadol, and tapentadol. So buprenorphine has been in the WHO armamentarium since '86, and tramadol may be promoted. One of the issues with tramadol, and this is US study, so there is a significant toxicity, and that there's evidence that there's 20,000 ED visits for abuse in the US. So it's a major problem in some areas of the world, particularly at high dose. And clearly, in high dose, it's implicated in serotonin syndrome and can cause hypoglycemia. And I won't talk about tapentadol, that's a really high-income country. And that brings us to the end of this discussion. And I'd be happy, depending on how things go with time, to take any further questions in the chat, or if they're given to me by Dr. Usman. So thank you very much. I'll stop sharing my screen and return you to Dr. Gauhar. Thanks, Gauhar. You need Mike.
So thank you very much, Professor Roger. And it is wonderful to hear a journey from 1986 that started long way, and now it is now. What is the status? Unfortunately, in 2018 guidelines, I was a part of the that guideline committee, and I know there's so many back and forth, and what you are recommending about the fourth ladder and all this discussion took place. But certainly there are so many variation across the globe, and radiotherapy and all these things comes in spite of these ladder. So thank you very much. If we have time at the end of the session, certainly we would like to have some questions, although it is a state of art, and we don't need to ask anything else after this very nice lecture. So now I would move on. So I would request Dr. Usman Bashir and to start a panel discussion. And the title of this panel discussion, again, is very interesting. Cancer pain relief without opioids, a challenge in LMIC. And there is a multidisciplinary group here, and Dr. Usman will introduce the group and the some of the format of this panel discussion. Dr. Usman, over to you, please. Dr. Usman. I think Dr. Usman is setting a slide share.
I think he might have just left actually to be coming back. He's obviously had a slight problem.
He just sent me a message that he can't hear anyone of us. Sophie, can you please help him out? He just sent me a message. Usman, I request.
Meantime, we can have chat with the other panelists. Gauhar, you can have a chat with.
I'm gonna try and ring Usman.
The question is understandable. Technology is something like question here is why don't some chat. Question here is
Gauhar, do you have
let
the
it
question?
take some time. Some questions you can always ask, like
Okay,
maybe
yes.
discuss. You can share your thoughts in Pakistan.
Okay.
Yeah.
So meanwhile, these things are settling down, so we can discuss what Roger actually was trying to leave some very, very important issue. The current literature that comes out after the updated WHO guidelines, where certainly, for example, the steroid issue, and he's right that the duration and how to start and dosage, some details are missing in this kind of a updated WHO guidelines. So how to we see this taking this steroid as the alternative of opioids, and then for how long and for all these things are maybe in the future literature would cover all these things, but currently this is a missing gap. So I think he's able to start the session.
Gauhar, just hang around, be there. The question here is he'll keep on helping us because sometimes Usman gets stuck. He can be there.
Okay,
Thank you so much,
I'm here now.
he's here.
Yeah, Usman, please.
So, hello everybody. Thank you very much for this rather very useful session. That was just a little IT glitch as we expect in this country. I happen to be at the moment in Pakistan, so there was a little internet glitch. So, without further ado, we'll start this rather very useful panel discussion. And we are lucky to have a very diverse panelists here, and privileged to have Dr. Muralidhar Joshi from India, who is president of Indian Society of Study of Pain and past president of ISA and past GC member of WFSA. We have Dr. Burkius King from South Africa, who is a specialist psychiatrist and current president of Pain South Africa. And she strongly believes in empowering people so that they can take charge of their own physical and mental health. We have Professor Akhter Zaman from Bangladesh. He's a pain physician and anesthesiologist, and currently the president of South Asian Regional Pain Society, Federation of IASP. And we are very lucky to have Dr. Adnan Jabbar, who is an oncologist and is a leading consultant in medical oncology in Pakistan. He did his training from USA and currently leading the oncology department in Ziauddin Hospital, Karachi, Pakistan. So welcome to all our esteemed panelists. The idea of this panel discussion is because we are dealing with quite an intricate topic of cancer pain management without opioids, that too in low middle income countries, and how to tackle the challenges. And I thought that the whole ethos of this panel discussion is to target at the diverse aspects with the help of our expert panelists among all these areas, so that by the end of the session, we can come up with some sustainable solutions and the way forward. So the idea will be to start with our diverse panels of experts, and then we will go along as we get more questions, and we'll conclude in the end. So I'll open the house with, first of all, discussion of about some particular aspects related to cancer as a whole from Dr. Adnan Jabbar, who is an oncologist. As we all know that in the last 20 years, the latest data from the low middle income countries is showing that there is a constant rise in the incidence of cancer in the low middle income countries, along with the mortality as well. And the numbers are projected to double in Africa and other low middle income countries in coming decades. So this is an alarming situation. So just to highlight this broader area, I have a question, firstly, from Dr. Adnan, that what do you think are the key factors leading low middle income countries to this situation? Because we are seeing, at one hand, high income countries, the overall cancer survival is increasing, the overall incidence is reducing, but in low middle income countries, it's the other way around. What do you think are the systemic causes to lead low middle income countries into this situation?
Thank you, Usman, for this question, and thank you to the organizers for inviting me for this important discussion. So the biggest challenge is, if I talk about my country, we are the 5th in terms of population, meaning we are talking about 240 million people. And on top of that, we are included in low middle income country. You just showed us some data, and the first thing I will say is I'm going to challenge your data. I think this data is underestimated. The first problem in a country like Pakistan is we do not have a national cancer registry. So if you ask me what is the actual burden of cancer, I think it's underestimated because of a lot of issues that I can pinpoint, but that would be beyond this discussion. But the biggest is that underreporting of cancer. So because of that, patient attitude, lack of public awareness, there are no clinical guidelines. I think cancer pain is a big challenge in my society. You talked about cancer incidence going up. It is because we have better medications, we have better diagnostics, we are improving in our healthcare, yet at the same time, we are not doing enough in a low middle income country like Pakistan to even attempt preventive medicine. I'm not going to undermine what is being done, but I think it is not being done enough. A country like Pakistan, besides the 5 major cancers like breast, lung, colorectal, our numbers of these infective cancers is going up. And I'll give you an example of hepatitis B and C, which is causing HCC. It's on a rise in our country. This is purely preventable cancer. And we all know the prognosis is really bad. So as you see better longevity in our society as well, the incidence of cancer is going up. So I guess the biggest challenge is there are no guidelines. There is no cancer registry. There's lack of awareness. And certainly there is lack of awareness about cancer pain, not only in patients, but also in the providers of healthcare in the public.
That's very well highlighted points, Dr. Adnan. But what are your thoughts on the overall healthcare infrastructure which supports? Because I'm trying to get to the overall backbone of all is a very well-developed healthcare infrastructure, screening programs, early detection, early treatments, which will all lead to overall reduced incidence. So how do you see it compared to where you got trained in US and now you are working in Pakistan? What is the difference which we are lacking here in LMICs?
There is lack of infrastructure, definitely on the public sector. One of the biggest challenge is the cost of all these tests. And we are talking about a country where the basic needs are not fulfilled. We are talking about a country where per diem your annual GDP is so low, where patients, even for the fact when there are some screening programs readily available, patients don't go for it. We have less than 5% mammograms in this country. Every October, we have these awareness programs where a lot of hospitals provide these free or subsidized mammograms, but people still don't do it. There's lack of awareness in the society. You can talk about major cities like Karachi, Lahore, where we have infrastructure available. But if you go anywhere inside into these small towns, there is not only lack of hospitals, there's also lack of service providers. There are no policies. If there are policies, people do not have the means. So I think, there is a drastic need of something to be done in terms of not only at the government level, but also at the public-private level to bring this gap behind. I can not even talk, compare coming from US, what we go through here practicing oncology in Pakistan. There's lack of medications, not only just the actual drugs to treat cancer, but we are talking about opiates. We run out of our analgesics in mid-air. And then all we have are these non-opioids, which we are trying to use to treat cancer pain. And I'll let the experts speak for that. So lack of these drugs is definitely one of the challenge. And the third most important thing is public awareness. If you give patient morphine, they think we are killing the patient. So I think there has to be something done at that level where we educate people that it's okay to be pain-free at a cost of what we all know happens with these opioids. Because in end of life, it's the quality of those last days that matters, not to be in pain.
Great. No, thank you very much, Dr. Adnan. That gives a very good background to all of us that where the root cause is lying. And that root cause is there, so that helps us to move forward to talk about the pain related to cancer, because of course cancer is increasing, so pain related to cancer will be increasing, and the challenges related to opioids. So I'll get back to you later on with some other specific question related to oncology, but I'll direct related to moving on from this part now, I'll ask Dr. Muralidhar Joshi, what do you think are the overall barriers at all the levels when it comes to cancer pain management in low middle income countries, especially without opioids? So if you can shed some overall light from your extensive experience.
Dr. Usman, I know I have only 8 minutes to stay for this thing, so but nice,
Don't
nice
worry.
you. No. Question here is, first of all, I would like not if you at least require Gauhar and maybe Clare or maybe Roger to note down. First of all, we have to change the definition of this WHO, this LMIC, MLIC, HLIC to HPLP. Gauhar, I want you to note down because Usman will be busy. Please note down, Gauhar. Please. No, and I don't want you to do. HPLP is highly populated. HPLP, highly populated. Low penetration, or like say low pay services, whatever you say, or other way around is HPLP. Highly, like you have enough money, but lowly populated. There are 2 countries, right? Don't 2 groups. Don't make it 3 groups. Highly populated, low income. Lowly populated, low income. Now, question here is now you got it. Don't make it 3 categories. Gauhar, am I right? I think she's muted actually. But question here is, see, let's understand. Let's understand from there. The question here is, I'll tell you very clearly. I'm telling you. I'll just in 2 lines only. One thing is, sir, our own. I would like to whichever country, what we are working and all. So we are highly populated. Where I'm working. My country is India. I'm happy about that one. We have the questionnaire is asking the patient to come regularly for this one, for opioid prescription, because we have licensed only for 1 month. Beyond that 1 month, we are not supposed to give it for safety reasons, because sometimes patient dies. Sometimes what happens, the son or daughter might start consuming the opioids. So that's our fear. So for us, somebody living on the hills and tribals and all, we decided between the nociceptive pain and neuropathic pain. Nociceptive pain, medications and all. It's nice to talk about NSAIDs, and again what is the WHO guidelines you say is not to use more for 10 to 14 days, and Roger was very clear saying no prolonged use. That prolonged use, that word definition, अंग्रेजी में क्या होता है, English? What exactly is prolonged use? Exactly what Roger meant. Question here is, it's not more than 10 to 14 days. Roger happens to be our he has helped us so much to do EPM program and all. Prolonged use, you see, as per the literature, not more than 10 to 14 days. Yes. So that's one. And second thing is, what I would like to suggest is, Usman, before I move out, and maybe another less than 30 seconds is, we prefer.
No, don't worry, it's taking care of time. So you can carry on, please.
8 minutes you have told me. So no, I'll come for second question. I'll join you. No, I'll tell you. Say, we talk Pakistan, you talk of Bangladesh, you talk Sri Lanka, or you talk of this one. But this category should go to LMIC, MIMC, and this HMC. Please, Gauhar, please understand, please. This has to go. Highly populated.
Yes, I understand. Yes. You are actually emphasizing the highly populated.
Highly populated.
With low, economy.
Low income, and the question here is like highly income and lowly populated. You cannot equate, right, Gauhar? Am I right? So it's a three.
Yeah, absolutely. Country. So that's what we are trying to.
I'm making it two. I'm making it only two. Gauhar and Usman, I'm making it only two. So
okay,
three categories.
Your point taken.
That's
so what we are trying to.
Yes, Gauhar, I'm telling you, Gauhar, Usman, I'm telling you, like in our own people stay in the village because they come to big city for treatment. And if you ask them to come every month for filling up the morphine, things, tablets you want to give, it's not possible, Usman. It's not possible, Gauhar.
And that's why we are holding this webinar to see what do you think.
No.
So I think, can I interrupt here? So I think Murali has been practicing pain for years and years.
Three decades.
And struggling. Yes, 3 decades. And he is really struggling to, certainly set up the pain services in India. So I think what we really want what the challenge, as far as, there are so many challenges, we all know that in the country where there's so much population and, the budget for healthcare is, so misery. So but whatever experience, because you as an expert, we really want your own experience, whatever literature said, that is the side path. So really want you, Murali, because
Gauhar and Usman, I got your message. I'm just giving an idea. Only two things. Question here is, wherever medication, say NSAIDs, we are saying at one point of time, we said not to use for 10 to 14 days.
Yes.
Right? We are not wrong about that one. But after, see, the whole discussion was about opioid free, the cancer pain management is fine. Yeah. But then at one point of time, the guidelines say not to use more than 10 to 14 days. Okay. But people are using for more than 10 to 14 days because there is no other option, or maybe a little bit more. One. And second thing is, I'll tell you again, Usman, you can almost stop me whenever you want.
No, that's fine. You finish your point, then we'll move on. Yeah. Finish,
so
please.
Because there are some Western countries, I'm telling you honestly, they start putting the pumps before going for CS stomach, celiac plexus block. So rather, I prefer a celiac plexus block working for about 9 months rather than going for a pump, because my people cannot afford. Maybe Pakistan, maybe Bangladesh can afford, but definitely not India. So I rather do celiac plexus block and send the patient home, And then maybe if he survives after 9 months, and then I might repeat the block, it's much more cost effective compared to putting a pump. I think Dr. Akhter Zaman also is around. And I know I leave this question for an open discussion. Maybe I am wrong, you can correct me. Over to Usman, Gauhar.
Very pertinent point, Dr. Muralidhar, because you are living and practicing in that part, and you are the best judge of the situation over there. So thank you very much. I'll come back to you later as well.
Cannot afford. I think you speak to Akhter and maybe.
So let me move on to Professor Akhter Zaman, taking on from your point about the interventions. Thank you very much, Dr. Joshi. That was very, very insightful. And from your point, I'll take on to Dr. Akhter Zaman on the same point, that interventions as part of non-opioid cancer pain management in low-middle income countries. From the point what Dr. Joshi is mentioning, from affordability, logistics, economic constraints, your patient population, what do you think? Where do the interventions lie in the journey of cancer pain, whether they should be done early or they should be done late in the context of whole this non-opioid management? Dr. Akhter Zaman, please.
Thank you, Usman. I start with the last word from Joshi. That Joshi says that he's putting on the celiac plexus blocks and giving the home for 9 months and come again with the for the pain management. Yes, I do that. So, Joshi, there is a two areas there. Are we prepared for giving the blocks or interventions for every area in this low and middle income countries? Though you are differing that like that this term, but if this term is based on the World Bank statistics regarding their income. So money at the end of the day, the money.
Sir, you said my thought, my heart.
No.
It's nice.
Because of that, if you see the article published in Pain Journal of ISP in 2003 or 2004, they are putting the three groups of people. So one group is only the intra-abdominal blocks, sympathetic blocks. Another group is blocks with the opioids, and another group is only the opioids. And they concludes that the blocks group is living in the longer time. The pain management is better, and the satisfaction is the better. And keeping in this mind, we have some this type of trial in my center in 2012, and it published in the ISP World Congress in Milan. So in this trial, we thought that the one group is giving the conventional pain management, giving the opioids, non-opioids, and sometimes in the combinations of the opioids, non-opioids, and paracetamols and other things. And other group is giving the celiac plexus blocks. Our hypothesis was, if we give the, as you know, that the opioids or in the pain management, all the medicines, it will cost a lot, and it is from the out of pockets, not is supplied by the government or any other agencies. So if he or she can giving the reduce the money costing for the buying the opioids and other analgesics, and only the giving the celiac plexus blocks for this pancreatic malignancy, and this money can be converted to their daily livelihoods. So that's why we conclude that the regional blocks, especially in the for pancreatic and upper abdominal cancer pain, we can give the earlier celiac plexus blocks, and we can make them the pain-free periods for at least for the 1 year. So it's our experience in the low and middle income countries. Like we are the representative of the low and middle income countries.
Absolutely.
But in case of the high groups, they are mostly depends on the opioids. Especially the WSL ladder is based on the opioids. They are giving the ladder 1, 2, and 3, and they are challenging the opioid epidemics nowadays. But on the other hand, we are not able to even make it available in the big cities like Dhaka, Karachi, Delhi, or or Mumbai. Yeah. So that's why we can move forward with the blocks in the earlier, and it can save the money, and it is possible to make it for the pain-free period, say, at least in a few months of these patients.
So conclusion is that you advocate, and as Dr. Joshi has said as well, that according to the local data demographics and the challenges, early intervention is better, both for logistic, economic reasons, and depending upon the population demographics. So maybe there is a need, as you have already highlighted, that you did a study from your data and prove it to be of benefit. So maybe it's a call to need for more high quality data from the local areas to promote the practice and to support our practice with evidence base. So thank you very much, Professor Akhter Zaman. I'll just come back to you later as well, but a slightly different area which I want to hit with Dr. Michelle King about from her role as a psychiatrist in this part of the world, in low middle income countries, we get quite a lot of ethical, cultural challenges. How do you think that the cultural beliefs and the practices in low middle income countries?
Can we change it to HPLP rather than LMIC? Can we HPLP?
I'm just sticking to the term given to me by WFSA at the moment.
Less privileged.
Okay.
For the time being, question here is only for this discussion only. HPLP, okay. Highly populated, less privileged.
Okay. So highly populated, less privileged. Thank you, Dr. Joshi.
Thank you,
Dr. King,
Usman, please just.
Okay, thank you.
It'll be easier for us.
Dr. King, my question is that how do you think that the cultural beliefs and practices in highly populated low-income countries influence the acceptance and effectiveness of cancer treatments, especially non-opioid related cancer treatments? How do the cultural beliefs influence that overall acceptance?
Thanks, Usman. I think when we're talking about non-opioid treatment of cancer pain, we're actually talking about palliative care at the end of the day, because it's not just about treating the cancer or the side effects of treatment. We have to treat the patient and their family holistically. So we're talking about treatments which might be psychosocial. So we're talking about treating depression, treating anxiety, treating bereavement, and not just of the patient, but of the family. So we need to be cognizant of the fact that the children in the family are going to be affected as well. And many cultures feel that you shouldn't be talking about death to kids. So that is definitely a huge barrier that I've experienced, that the kids are completely excluded from treatment because you just don't talk to you don't talk to children about death. The other thing that I experience a lot is just people's attitude about pain and that health-seeking behavior in general. And regardless of what your cultural background is or your spiritual background, within each cultural setting, there are these different behaviors. So I'm sure the one that you experience so much is that belief that you have to be stoic, especially in our culture in South Africa. Men don't cry. Right? Men don't experience pain. Men can't be seen as being weak. So you don't tell your doctor you're hurting or that you're in a lot of pain because you just don't do that, right? Men don't talk about being weak. The other thing that I see is people might not tell their doctor that they're in pain as a sign of respect. So if you're telling your doctor your pain is not controlled, you're implying that he's not good at his job, or that what he's given you is actually not a good treatment, that he's being ineffective. So as a sign of respect, you rather keep quiet so that you don't put him in a bad light. The other thing that I see sometimes is that there's this attitude that cancer is supposed to be painful. Death is about suffering, and whether that's a spiritual belief or a cultural belief or just a human belief. So if you have this idea that, well, I should be suffering, I have cancer, you're not going to let anyone know how bad your pain is.
Great.
Another attitude that we see is you don't want your family to worry. So you keep quiet. Because if you're experiencing a lot of pain, everyone's going to worry. And so people actually try to keep all their symptoms and hurts to themselves in order to protect their family.
Absolutely.
Yeah, and the other thing is the spiritual belief that, I don't say Western medicine, because palliative care is so broad, but that your doctor and the opioids isn't the right treatment for you. So you end up going to see your traditional healer. So you're not accessing the other broad range of treatment options that might be available to you. And then for me, the most common thing, and I don't know if you experience this as well, is this whole attitude that palliative care is only for the dying.
Absolutely.
You know, so instead of accessing treatment right at the time of your diagnosis, you're only getting it on your deathbed.
So how do you see, like, you've correctly highlighted all these challenges, which I faced as well when I practiced in Pakistan, that all these cultural limitations and the cultural beliefs are very, very strong. And I don't know what Gauhar and Dr. Joshi might agree as well, that one difficulty in this part of the world related to cancer is that do not disclose the diagnosis to the patient. And this is extremely difficult ethically. So we face it in our part of the world. We face it every day that the family says, don't tell the patient that they have terminal cancer. And that puts us in difficult situations. So how to deal with that ethically, psychologically, when to be faced with these issues. So what do you think? How to incorporate these things into the healthcare systems? How can we approach as a patient-centered care in this cultural aspect? What practices should we promote? How do we overcome this barrier? If you can get your
I
thoughts.
think you actually answered it yourself in your last comment. We have to follow patient-centered care. And unfortunately, in so much of our training, we still, I mean, when I qualified, it was still very, very paternalistic. You know, your doctor's the one with all the answers. You must respect the doctor. You never challenge them. And a lot of the doctors carried that attitude into their practices. So patients don't ask questions. They're not educated about making, or that they have the right to make informed decisions. And that's when we see problems like this starting to happen, where the families don't want the person who has the cancer to know about their diagnosis. And the only way we fix that is by following a patient-centered approach. And I know this issue comes up frequently, and I love these panel discussions because I realize we're all so similar, regardless of where we're living. We're all just human at the end of the day, and our challenges are the same. But this whole thing where you want to protect your loved one from the suffering and from the anguish, but in doing so, you take away so much of the journey of life, and part of that is dying. You know, and in our hearts, in our efforts to protect people from that suffering, we take away their ability to go through that process, you know, and it's emotionally complicated and beautiful as well. But you got to say goodbye, and we can't, from an ethical perspective, we can't want to protect or stop suffering and take that opportunity away.
Absolutely, absolutely, very insightful. Thank you, Dr. King. Just a question from Dr. Joshi. What are your thoughts, given all these constraints and limitations, does technology has any role to play to hinder any of these problems?
Dr. Usman, Gauhar also, please. Gauhar, you also be online, please. HPLP, you know. Please note down. See, I might have missed something. Highly populated, less privileged. Less privileged, highly populated. Please note down. Question reason being because, you know, these things might come for some discussion. We are not against anybody. HPLP, highly populated, less privileged. Less privileged, No, less populated, highly privileged. One. Second thing is technology. Gauhar, you also can note down this one if you're around. Actually, we are working on that
Yeah.
one. What's happening is that Usman, there are. See, I told you very clearly. We are talking about opioid-free, whatever the cancer pain management, right? We talk NSAIDs at one point of time. NSAIDs we say not more than 10 to 14 days. We are not. See, grossly. I'm not saying, but it's okay. But question here is, you see, question then we have got two categories of cancer pain, right?
Yep.
One is peripheral, like for example, I might in upper limbs or lower limbs, or might be in my abdomen, right? So the peripheral limbs and lower limbs, we are working on a project actually. Say for example, I have got a cancer in like I got a sarcoma in lower limb.
Yep.
I can rather put a I can ask somebody to put a local anesthetic pellet which can work for 6 months or 8 months or 9 months, which I can set the duration. The work is on. It's not speculative. Say, for example, your bupivacaine, how long will it work? About 240 minutes. Highest. Roughly. 120 to 240 minutes. Bupivacaine. Usman, am I confusing you?
Yep.
So, if that local anesthetic can work for about, say for about 6 months, anything wrong?
No. So what I
Right.
meant to ask was that, do you see any role of
There was
because in the
second
current,
question for me, new technical developments you asked me. This is
yes,
what
yes.
we are working on. So pellets means, for example, simple thing I'm telling, ultrasound guided. I put this kind of pellet loaded this thing solution over the femoral nerve for a liposarcoma of the lower thigh pain. It works for 6 months. Is there anything wrong with that one?
No, it's a very good use of technology
So
according to
okay,
the
you asked for
audience.
department. So I'm talking peripheries, upper limb and lower limb. Same thing apply upper limb as lower limb also. And the visceral pain also we are working on that one. And the question is we have to see what helps people and all. But if you ask me, somebody sitting in Himachal Pradesh or Kashmir hills and these things and all, it becomes difficult. It's difficult to call him every month because he has to prove that he's alive. I think it must be same in Pakistan also. I don't think.
Yeah,
Because
absolutely.
we are not,
So
we are not
what I meant
supposed
to
because
get the panelists.
technologically, I'm just looking because because the discussion was about non-opioid medication. That's why I spoke. I'm doing something else in opioid also, but I'm not talking at this stage.
Yes.
But
What I meant to, thank you very much. Very good. Excellent. So Michelle has something to say here. So if you can unmute her. You have any point on that?
I'll move. No issues.
So Dr.
So,
King?
yeah, Usman, to answer your question about the use of technology, we are launching a program, hopefully within the next few weeks in South Africa called the Patient Support Program. So the idea then is that the oncologist or treating doctor then registers the patient with their consent to this program. And the patient then has access to several different topics, talking about pain relief, non-pain symptoms, or the biopsychosocial approach to managing their pain. But then they also have video clips that they can then share with their family members to educate their family members as well.
Absolutely.
So I think we really have to be creative in how we use technology to promote health education.
Great.
Because we've got to start challenging these beliefs, and it's a good platform to do that.
So there is a role of technology when it comes to telemedicine, even these webinars, teleconsults, distant consults. I know we are talking about remote areas, highly populated, low income countries, but still there is a role of technology to move things forward, to fill up these bridges, to fill up these gaps. And like Dr. King is saying, that they're making use of that. We still have some time. So a follow-on question from Dr. Adnan Jabbar, because at the root cause of all of it, you rightly mentioned that we don't have data, we don't have registry. When it comes to cancer care and cancer pain care, what do you think is needed in the research world in this part of the world, or in the highly populated low-income areas? How can we work in the research and development area? What solutions do you propose for that area?
So, you know, as Dr. King was talking, it was like echoing my sentiments, the challenges that I daily face with my patients. So one of the unfortunate thing is that we work in silos. We like to invent our own wheel. The thing that I would love to do is we have these experts, panelists who have spent time, 30 years of experience in India, and so on and so forth, to help us, guide us, to create guidelines. And not only create guidelines, because there are several guidelines, but also help us implement that, because our challenges are the same. I mean, what Dr. King was saying, that a patient's interpretation of pain, the challenges of asking the doctors or telling them that they are pain, I hear it, I see it every day. So if they have learned from those experiences, I don't want to create something new. I would like for these panelists to guide us, how they came up with these challenges, share our challenges and share our solutions, which I'm sure are out there. We were talking about use of technology. So we use a WhatsApp group where we ask our patients to send us whenever they have any symptom, whether it's diarrhea, loose motion, nausea, vomiting. And that has helped our patients tremendously. For them to wait until next morning, all they need to do is text their concern, and we tell them, if it's an emergency, you come to ER. But if it's just a simple question, any one of our volunteers take that and they answer, which is exactly what Dr. King was saying, that they have access to those things. So I think my thing would be that help us create these guidelines in a country where we do not have these medications, where we run out on them. I saw a slide where we use, in my part of the world, tramadol is available. That is all we can use along with buprenorphine and tapentadol. I understand those side effects, but unfortunately, if that is the only thing that can help my patient, I end up using those. So I think that, in short, I would like the panelists to help us create guidelines and help us in using these guidelines in our society.
Yes. So absolutely. But don't you think that, as Dr. Joshi and Dr. Akhter Zaman has mentioned as well, that the data has to be relevant to the problems that we have here? So, and the guidelines have to be accordingly, rather than, because the Western world, the high-income countries, they have developed it according to their situation and the overall demographics. So demographics in our area are totally different.
Dr. Usman, HPLP.
So we need to sit together.
Dr. Usman, HPLP. Highly privileged.
Yes. HPLP. Yes, absolutely. Don't worry. We'll
Yes, Dr. Usman.
Absolutely.
So hence, when we will sit together, people like Dr. Afshan, people like Dr. Salam, they are the ones who have worked, and they will guide us to make these guidelines, knowingly the limitations. We get these NCCN guidelines to treat our patients, but then we sit and we say, hey, listen, you are saying this is the best practice, but I have a challenge of non-availability of this drug. So what is the minimum that we can do? And that is what the people like Dr. Gauhar Afshan, people who have worked in these low middle income countries who know can help us.
Great, thank you very much. Just one more question from Professor Akhter Zaman, because he has done work in that aspect. One challenge that I faced in the cancer pain management, because it has many facets to it, many categories of pain management, plus integration with the oncologist, integration with the surgery, all the different non-opioid treatments requires a multidisciplinary team approach. how do you see the role of MDT approach in developing countries, HPLPs? What are the barriers to MDT, multidisciplinary team management, and how would you propose any solutions to come forward to that?
Thank you,
Professor
Dr.
Akhter,
Usman, for using the word HPLP. Thank you, Dr. Usman.
Joshi, yes, of course. The low and middle income countries, we are the actually your groups, the SPLC. Yeah. So we because of that, like in Bangladesh, Pakistan, we are very small country, but densely populated. And on the other hand, the densely populated with less income. So we in the other word, for the low and middle income countries, we can make it the nomenclature that highly density and low income groups. So we are your groups. Don't worry about that. So the multidisciplinary team approach is the only things that can be implemented in the non-opioid based pain management. So we have the WHO and All Federation of Anesthesia and IASP has got some they have the multidisciplinary team approach guidelines. Even the IASP recently they have they make it in the manual to how to run and how to establish and run the multidisciplinary pain management team in this area. So IASP is working on that. In the other word that this year, the 2023 is the integrated pain management, pain care is the ISP global year slogans. So the WFSA and ISP and Asia Pacific Hospice can move together and can make a consensus on the pain management for the low and middle income countries like these areas, or the on the word of the Joshi that it is a highly density low income groups.
Great. Yeah, so thank you very much for pointing out to that IASP toolkit, which they have relatively recently published to help this area to develop multidisciplinary teams, which is a very much need. So that has been a very, very fruitful discussion. And I thank all of our esteemed panelists for helping us move forward in terms of very relevant point. And I will close on this because a lot of this discussion is culminating to a point, and I'll open it to the all house of panelists or maybe to Carolina, that how do we move things forward in terms of innovative collaboration between low middle income countries, HPLPs, for Dr. Joshi, okay, HPLPs and
Thank you, Usman. Thank you,
the high income countries, okay. So how do we move forward in terms of partnership, collaborative partnership, of collaboration? Like this webinar is one of the examples of them, but how do you see the way forward, even in terms of helping us develop guidelines relevant to our situations? What will be your comments on that?
Usman, can I interrupt you if you don't mind?
Yeah.
I was just thinking that if you'll take a first question answers from chat box,
Okay.
I have forwarded to you, and then Carolina will certainly then would have an idea of what the panelists said and what the people are thinking around the globe.
Okay. Great. So we had a very engaging audience. So we have some very interesting questions, and the answers are open to the panelists with their own wide experience. First question which I have is, how do you see the role of ketamine when it comes to overall non-opioids treatment in HPLP areas? Any experience from any of the panelists who have used ketamine in the cancer pain and the palliative care? Open to all panelists.
It's not safe. It's not safe. The problem is not the ketamine. Is not the ketamine is wrong. Sorry, Usman. Just this time. Yeah. I'm only here. So question is, it's not the ketamine is wrong. The question is our decision is wrong. The question is what is happening is these people come to, because the ketamine works for about 3 to 4 hours or maybe maximum 6 hours, and these people come again and again. And we had this person who's dying actually I think this one of the friends actor, I think Philip, something like that, I think. The ketamine overdosage, and also we had Michael Jackson. So I don't recommend. As a, because otherwise they keep on coming to your ER for ketamine
So the
injection.
problems with ketamine are too much
The
to
question
be
area,
dealt
that's what I see.
safe.
Question, when we are advocating a non-opioid medications, but ketamine is much worse than opioids.
Good, good. Thank you. Second question, which is very interesting, again, open to the panelists. If the government bodies are not providing enough support, can the society itself develop support systems for this much needed area, and how can it move forward if the government bodies at higher systemic levels are not providing enough infrastructure? What can community do to make appropriate forward moves? And any such examples in your practices where community has moved forward?
We had I don't know, maybe Akhter, maybe Gauhar can express this one, but we look at ourselves as an Indian society. For society, we are society. We are not regulatory authority. I don't know how Gauhar looks at her own this thing, or maybe Dr. Akhter also. We are not regulatory authorities with respect to opioids, because a lot of manufacturing. See, that's what I'm saying. Highly populated, less privileged, highly privileged. Question is, that's what I was just wanted to. The question is, lot of contraband substances get produced in our country to supply to the highly privileged people with less populated. That's the whole reason what I said. Maybe Gauhar is nodding her hand. Question here is, sir, we are society, sir. We are only society. Even WFSA, what is it? World Federation of Societies of Anesthesiologists. We are not regulating authority for world. Please understand. Again, repeat. What is WFSA? World Federation of Societies of Anesthesiologists. We are not regulating authority, but each country has its own laws and all those things, which we respect. But it's only the question here is, each country can take up the challenge as per their comfort zone. What is approach? Dr. Akhter and Dr. Gauhar can explain, because they have their challenges.
Gauhar, can I make just one point? Is that actually the Usman is probably asking in the society as well as in the community,
Yes.
in the affluent groups or in the philanthropic groups can dedicatedly establish a service for the cancer pain management. Like in Dhaka, we have three or four groups for that is for the home care. So far I know that in India there is a lot of groups are coming forward for giving the free of medications, even in the services in the home doorsteps of the cancer patients. Yeah. So it can be possible. It can be a social movement. It can be a political movement. So it can if it starts in the one country, it can be motivated by other groups. So I think that Usman is initiating by indicating these sorts of initiative. Yeah.
So we have positive examples, like Professor Akhter Zaman is mentioning, and it's a matter of taking these positive examples as a role model to create the bigger fulcrum at international level, at the state level, if we have positive examples. So one more question quickly. Thank you very much, Professor Akhter Zaman, Dr. Joshi. One last question from the audience. What are your thoughts on training the local general practitioners and family physicians on managing the cancer pain and the follow-ups related to that, so that there is less burden on the tertiary centers and the pain specialists? Anyone from the panelists?
Yes.
So
Can I
training the GPs?
Yeah. We have started the Rojar is there. Probably the Rojar and Maurice, they have started the essential pain management groups. This essential pain management can be initiated in every levels. It's from the nurses, from the GPs and others, and it will help and it will create a great movement for managing the cancer pains, or even in the back pains, or in the chronic pains in a definitive ways. That's why I thank Rosa and Maurice for giving the free versions of essential pain management lecture toolkits. And we the Bangladesh Society for Study of Pain started this EPM in 2013, and we are going to the GP levels for treating the one-day EPM for the GPs for treating the pain, especially on the cancer pain.
So great. So there are examples, positive examples everywhere, which can be taken forward.
Actually, Dr. Usman, I think I still have some.
Yes, Dr. Joshi.
Few minutes for this.
Yes.
Actually, I'm telling you, like, for example, Usman, if you should relax, you are holding your neck tight. Just relax. Question is, we have a situation actually, like, a lot of. See, we look at this like, this is a new career for the youngsters, pain medicine. But I have some solid, lot of seniors in India who have started this course. I'll tell a simple thing. Usman, you're quite young. You must be around 18 years or 19 years.
I mean, 40s, early 40s, yeah.
No, I'm not. Then you should take it a compliment. Gauhar is also looking at you. So question here is, it's okay. Like it's okay, fine. The question here is, like, we have to understand, it's not just for the youngsters, for seniors also. I'm telling you one. I think you had a question for that one. Any classical example for this kind of cancer pain management, right?
Yes.
But please, if you permit me, Dr. Usman, I'll sit that one.
Yes.
Eye opener for everybody, actually. Somebody in Kerala. Kerala is nothing. It's an over like, western coast on this thing. And the parents, husband, wife, and one son. And son became a doctor. Husband was father was a doctor already. And the son and doctor, they thought he'll settle in Kerala. Kerala, Kerala is western coast. Not Kerala. So he constructed the double-story building. I'm telling you, this is the ground reality. What happens? Please understand this one, because this we can present it wherever we want to project. Or you and Gauhar can present it. So he constructed the house. It's fair. He wanted, like, me and my wife will settle in upstairs, and the ground floor, son and his daughter-in-law, what a family they run. But as usual, what happens? Son went to US or somewhere, Western countries somewhere, and then he went and he settled and he was comfortable. He did not want to come, and then he did not know what to do. They went there for about, like, one monsoon or second monsoon. Then they did not know what to do, because they came back. Then they said they did not know what to do, so they were staying upstairs. Then he started pain clinic in the ground floor. Please understand, this is where the whole story starts. He started the clinic in the ground floor. Imagine, he was 65, wife was 63, and he used to carry a cup of tea in a flask. And sit there because he just wanted a company.
Okay.
Great. Thank you very much, Dr. Joshi. I'm just being told by admin that we are running short of time, so I'm sorry to interrupt. No, very insightful.
No, he offered a cup of tea to everybody who came, and he was happy.
Thank you very much.
And he lived happy. I'll stop it here. I understand.
Great. Thank you very much, Dr. Joshi, and thank you very much to all our panelists and our very much engaging audience. Very interesting questions and very engaging conversation. And I'll let Dr. Gauhar and Dr. Carolina take over to conclude the session. And one of the concluding questions which I had in mind, that how do we take things forward in terms of collaboration between the high-income bodies and low-middle-income countries, and what are the suggestions and the proposals? Thank you very much. Okay, thank you. Thank you, Carolina. Thank you, Gauhar. Thank you very much, everybody. Thanks to all the panelists. Dr. Gauhar, you're muted. Unmute yourself, please.
Thank you very much, Usman. You really conducted very well, covering all the aspects in limited time, giving the time to all panelists. And I'm very grateful. The WFC committee is very grateful to you. So if Carolina is online, then we can try to, close this discussion. It is a very interesting discussion. I'm waiting until the Carolina would come. And
thank you. I'm right here.
Oh, thank you very much, dear. Thank you very much. Okay, Carolina. So over to you. So I'm sure that you have heard that Roger's a very nice state-of-art lecture and a very informative discussion, the hottest sometime of this panel discussion. So please go ahead, Carolina.
Thank you very much. Well, to sum up with some concluding remarks, thank you all for attending this last cancer pain webinar regarding cancer pain relief without opioids and a challenge in our constrained environment. Thanks to the Pain Management Committee for setting this series. And thanks, Roger. Roger Goucke presented a great state-of-art lecture, an update of WHO Analgesic ladder. And thanks to a group of prestigious panelists showing their insightful perspectives regarding their progress and challenges in their local practice and constrained environments or less privileged environments. I live in Honduras, considered by the World Bank a low middle income country with 9 million population. So it's a small population, less privileged, of course, but with the same challenges mentioned by the panelists. Both in Honduras, both extremes of economical environments exist. So in the same country, we have a privileged population, but also less privileged, and that's the higher amount of people. So we have several things to say about all our webinar. It has been amazing, very insightful, because we have presented right here, the panelists have presented their experience in their practice. So there are some things we can do, of course. If we highlight some things like underreported cancer data, underestimated, and cancer is arising in some countries, we are aware of that. And of course, cancer pain too. So this lack of awareness, not only in patients, but also in healthcare workers, lack of infrastructure in public sectors, although programs in some countries are available. So to bridge this gap of lack of medication, including opioids, and as Dr. Adnan said, running out of analgesic by mid-year. It was just like hearing what is going on in Honduras, the same. We are all living the same challenges. And so it is so important to educate people. This is one of our strategic, the WFSA strategic words: educate, collaborate, advocate. It's very important to educate our population, the existing in Latin America, for example, the opiophobia, and as mentioned by the Latin American Federation, we have also opio ignorance. So it's very, we have a lot to do about education. We don't have much pain units. We don't have much palliative care units. So to include such a also special population like pediatric patients, we don't include much about this special population, and it's also suffering from cancer pain. And independent of culture, pain is there, but definitely culture influences to be, sometimes, and right here in Honduras, the same thing, to be stoic. And some attitudes related to some myth are, sometimes are barriers to cancer pain relief. Also, I must say that to implement some of the follow patient care focus resources and education to the population. It is so important, including technology and telemedicine. So we can see there are different resources, different countries that we should learn from each other. So these webinars are, one of the goals is this, to share what is going on in different countries and that have very constrained environments. Okay, and to be sure also that patients have access to these technology and all these integrative resources. We can be a highly populated, low and middle income countries, but more challenges, of course, to be faced, but also this lack of opioids or restriction for its use or their prolonged use in some places. It's also in small countries, and it's difficult for patients to come every month or every 14 days to fill their opioid requirements. Sometimes we rather to make a long-term block, and we are the same in Honduras and some parts of Latin America. It is sometimes more cost-effective than for patients to be coming to the main cities to get their opioid requirements filled. Okay, and beyond identifying these gaps in global access to cancer pain relief, we as individuals in our different environments, instead of working as silos, as one of the panelists said, we as part of the human family, we must strengthen relationships and dialogue with international organizations aiming for the same goal, and go, advocate and talk to policymakers, not only on the ground and our local governments, but also at WHO. So the WFSA, and as a non-state member, is also doing this type of efforts with statements about pain and statements about palliative care. Lastly, I should say thank you all, thank you very much. We have learned from each other. I think sharing is so important because we are, taking ideas from what all the countries are doing and all the experienced panelists are doing. Thank you again. And I must get this last few seconds, a gentle reminder to our Olympics, our World Congress of Anaesthesia 2024 in Singapore next March, where we will have cancer pain sessions, cancer pain workshops, and lectures to continue deepening in this topic. Thank you all.
So thank you very much, Carolina. And with this, I think we are just finishing our session time. So thank you very much, Carolina. Thank you very much, Claire. All my respected panelists, the state-of-art lecture presented by Dr. Roger. Thank you very much, and hope to see you again in the same forum. Thank you very much. Thank you.
Thank you all.
Thank you, Gauhar. Thank you all.
Thank you very much, Adnan.
Bye.
Thank you.